Good evening, everyone. Just to make a correction, I'm not Dr. Elsayed. I've been asked to step in. He couldn't make it this evening. My name is Karim Abdelaziz, and I work just up the road at the United Arab Emirates University. And it's a tremendous privilege to be here this evening to talk to you about depression and heart failure. And I'd like to start off the presentation by showing a slide, which I think reflects reasonably well the reciprocal relationship between depression and the heart. And it starts off by saying depression is bad for my heart, and my bad heart is bad for my depression. And I think that kind of reflects the relationship that these two conditions have with each other. So is depression important, particularly for heart failure? Certainly from a global perspective, depression is now recognized as the world's second leading cause of disability, and this is from 2013. And just another article in the news a few months ago, depression's costing European businesses about £77 billion, this is UK pounds a year. And so some statistics, 350 million people worldwide suffer from depression, so that's about 1 in 20. And depression is related to suicide, and there's about 1 million lives lost a year to suicide, so that translates to about 3,000 suicides a day. So if you're thinking in terms of an analogy, that's like 9/11 happening once every day for a whole year. Not only that, but for every completed suicide, there's about 20 or more attempted suicides. So as we said, it's currently the second leading cause of disability, but the WHO predicts that by 2020 it will become the leading cause of disability worldwide. And because we live in an age where money is important, so $83 billion annual expenditure from the burden of depression in the US, this is the year 2000, and as we just said, 77 billion pounds a year in Europe. And from a heart failure point of view, it costs about, it contributes to about $5 billion for the total bill for heart failure. So how common is depression in heart failure? So the biggest study done on this was by Rutledge and colleagues in 2006, so they reviewed 36 studies, and rates varied from about 14% to 38%, but they had an aggregated prevalence of about 21.5%. And here's a nice diagram to illustrate that for you. Basically, the rates varied depending on how strictly or not criteria were applied. So the less strictly applied the criteria, the higher the rates of depression. The assessment tools used varied, so there are about 6 different assessment tools in all the studies, and there are about 10 different severity rating scales. So considerable range of rates there. In terms of heart failure severity, prevalence tends to increase the more severe the form of heart failure. So just some figures there. So 11% for mild heart failure, 20% for class 2, 38% for class 3, 42%. And we have it illustrated on the bar chart there. In terms of systolic versus diastolic heart failure, there wasn't really much there wasn't any statistical difference between systolic and diastolic heart failure when compared to each other. But when compared to both healthy controls and controls with cardiovascular risk factors, there was a significant difference both in terms of prevalence of depression and severity. So some demographics, numerous studies have been done on this, and females consistently found to develop depression more than males, more prevalent in younger patients, and depression is associated with poorer outcomes in heart failure. So an increase in both the risk of hospitalization and in readmission rates as well. So depressed patients with heart failure had poorer functional outcomes and poorer quality of life measures compared to non-depressed patients, more likely to receive heart transplants, and less likely to adhere to medication such as ACE inhibitors or beta blockers. So in terms of mortality, numerous studies have demonstrated an increased risk of mortality in patients with a history of depression. Some showing almost a twofold increase in mortality if you have depression or heart failure. And the risk of mortality increases with time if depression continues. However, what most studies didn't highlight was the risk of mortality associated to a particular cause of heart failure, and that's where research is lacking. And here's a Kaplan-Meier curve to demonstrate. So you have the x-axis showing mortality rates, the y-axis showing time from discharge. So the dotted line represents patients who have heart failure plus depression. The solid black line represents patients. Solid line represents patients without depression. And as you can see, the p-value highly significant there, and depressed patients consistently have higher mortality rates. So what of the pathophysiology of depression and heart failure? So far there are no proven theories to explain the comorbidity. It's not related to sort of poor cardiac pump function or even underlying cardiovascular disease. It's hypothesized that mechanisms leading to depression in heart failure are pretty much similar to those that cause heart failure themselves. So things like autonomic dysregulation, increasing prothrombotic platelet activation, elevated cortisol, increased inflammatory cytokines, interleukin-1, 6, and TNF-alpha. Here's a nice complicated diagram from Musselman and colleagues, sort of demonstrating the complicated interrelationship that cardiovascular disease has with depression. So what of clinical characteristics of heart failure related to depression? So of the 9 defining characteristics of depression, 4 of them overlap with heart failure. And just sort of to highlight that, so on the left there you have symptoms of heart failure alone. On the right you've got depression, and in the middle is the common symptoms. So quite a few there. Okay? And that undoubtedly leads to difficulties in disentangling cause and effect relationships. In addition, the biobehavioral processes involved in heart failure, for example, reduced physical activity, can also increase the risk of depression. So how do we distinguish depressed patients from those only demonstrating signs of heart failure? So McDaniel and colleagues suggested 4 approaches. First one's called the inclusive approach, and basically you count all the signs and symptoms described by the patient, whether these symptoms are attributed to heart failure or not. It has one advantage and one major disadvantage. So it's highly unlikely that if you include all the symptoms that you'll miss out someone with depression. But undoubtedly this is going to lead to overdiagnosis and a high rate of false positives. And practically speaking, that leads to increased healthcare expenditure. So the etiologic approach, basically, you only include the symptoms of depression if you can demonstrate that they're not caused by physical illness. And that's actually pretty unreliable because it's not always easy to tease out what's causing what. So it's a pretty unreliable method. Another method suggested is that you eliminate the confusion altogether by removing those symptoms of depression which can be attributed to a medical illness, and including other symptoms, new symptoms, to help avoid the ambiguity. And what they suggest, for example, is that, for example, irritability instead of loss of energy, not specifically a diagnostic criteria for depression, but commonly seen in patients with depression. And a couple of other examples there. Okay. Difficulty with that is basically there's no agreement on what is an appropriate disposal or a substitution, and again relies on unreliable individual judgment. And finally, last approach is the exclusive approach. So you completely ignore any symptom that can be attributed to a medical condition, and you only include those symptoms that you are sure is due to the depression itself. Again, high possibility of false negatives because you're potentially excluding a lot of symptoms there. But realistically speaking, as physicians, as cardiologists, do you really have that amount of time to sort of disentangle, what is physical and what is psychiatric? Probably not. So probably a more realistic approach is what's being suggested here. So one simple question can effectively screen for depression, and that simple question is, surprise, are you depressed? And surprisingly, it's a highly sensitive question. So 55%, so when you consider that single question, can pick up about 1 in every 2 patients with depression. So, don't hesitate to ask the question if you think it's there. Okay. Again, if you're busy and you suspect, okay, there are some screening tools that can be used in depression, and the one suggested here is something called the PHQ-9, and it takes about 5 minutes to complete, and you just give it to the patient and they will, they will complete it themselves. 83% sensitivity, 90% specificity. And there's a lot of support from the literature in its use in depression in cardiovascular conditions. So, depression really shouldn't be that difficult to screen for, okay? And of course, if still in doubt, consult a psychiatrist. Okay. So what of treatments for heart failure and depression, okay? Antidepressants, obviously still the first line. Tricyclics, very little data on its use in heart failure. Recognized cardiotoxic effects, rhythmogenic QTC prolongation, bundle branch block, AV nodal block, and even increase the risk of mortality. So not recommended to be used in heart failure. SSRIs, okay. Most of the data done with SSRIs focused on ischemic heart and coronary heart patients. Some evidence for its use and safety in heart failure patients. A couple of studies from 2007, one involving paroxetine and one involving sertraline, both shown to significantly reduce BDIs, something called the Beck Depression Inventory, so that's basically a depression severity scale, so significant reductions in depressive symptoms. But as you can see, both studies with small samples, 27 and 20, so really results can't be generalized. And then from 2008 there was the SAD Heart for congestive heart failure trial. So it's a sertraline antidepressant heart attack randomized trial in patients with chronic heart failure. So large number of patients, 469 with heart failure and depression, half randomized to sertraline, half to placebo for 12 weeks. Okay, so pretty big trial. Okay, but disappointingly, no significant difference between sertraline and placebo in terms of treating depressive symptoms, and certainly no evidence for it improving heart failure parameters such as mortality and hospitalization. But despite that, both groups had significant improvement in depression, so there was no difference between the two groups. And that was attributed to the fact that there was extensive nurse-facilitated support and highlighted the need for better nursing care in patients with heart failure. Another trial that's ongoing at the moment and started in about 2008-2009, involving 700 patients. So it's the mood for heart failure. And this one's using an SSRI, escitalopram. Results were expected in 2014, but last I checked, there isn't even any preliminary results. So that's something to look forward to. Other antidepressants, very little to support its use. So bupropion, one small open label trial from 91, no reported efficacy. Non-pharmacological treatments such as cognitive therapy, again, very few studies specifically examining this in heart failure. And of the 8 trials examining cognitive therapy in cardiovascular disease, there was only one that specifically looked at heart failure patients, and that was Costas and colleagues from 94, which did show a significant reduction in Beck depressive inventory scores. A more recent study, small pilot from Friedland and colleagues, involving 20 patients with CVT, again showed some promise in treating symptoms. So in conclusion, although we have guidelines for treating depression and coronary heart disease, we don't have anything similar for management of depression and heart failure. Best treatment strategies are still unclear, and a lot more research is needed. And thank you very much.
you very much for inviting us in a field that we don't know a little about. The question is, I think the picture is very gloomy now in the way of offering a drug that help these people. So how would we deal with them then?
Well, basically we have to keep trying. I mean, there's a need for a lot more research, obviously. It's not to say that anecdotal reports aren't promising. The large-scale randomized controlled trials just aren't there, or the ones that have been done aren't showing promise. Probably what I would recommend in heart failure is that basic principle is do no harm. So you continue to treat these patients with medication. There is a high placebo response anyway, but whether that translates into whether we should be giving these patients SSRIs is still yet to be proven on a larger scale. But I would say basically treat without doing any harm. So yes, continue giving SSRIs. They are the safest antidepressants out there from a cardiological point of view and from a heart failure point of view. Obviously we can't leave these patients. Psychological therapies are showing promise, but again, still a lot more research needed.